I now invite Dr. Vanita Pathak. Madam has been a pioneer in doing endocyclophotocoagulation and tube shunts for the longest time that we've been here. And our very own Professor McGonigal will talk about how tube shunts are here to stay, but with what modifications. Over to you, ma'am.
She's a pioneer in many other things also.
Thank you very much. I have no relevant disclosures. So let's dive into this straight away. GDDs that are available in India and their relative surface area. As you can see, the valved ones are the smaller ones, Emmett glaucoma valve, FP8 and FP7. On the other hand, you have the non-valved ADI and the Emmett ClearPath 350, and somewhere in between the non-valved Emmett ClearPath 250. What is the difference, relative difference between the two? Of course, the valve one has a valve. On the other hand, the non-valve ones, the chance of hypotony is more in the early phase, so you need to use standard means to control, hypotony. Plate size is smaller in valve. We have already talked about it, and the advantage of that plate size is that it can be placed between muscles, whereas you have to dissect out muscles in the larger plates. And the disadvantage of this small plate size is that it, you cannot achieve low target IOP. That is not the case with non-valve, and the hypertensive phase kicks in much earlier with the valved. So how does the non-valved one work? There is a fibrous capsule formation around the plate 4 to 5 weeks. This then acts as a reservoir. Between the capsule and the plate, you have aqueous, which then diffuses out passively. And this, of course, does not happen. This takes time, so that therefore you occlude the tube. IOP reduction, therefore, is dependent on the surface area of the capsule, and that, of course, is dependent on the end plate size and the thickness of the capsule. So when you want lower target IOP, you can, you achieve lower target IOP when the capsule is thinner with larger surface area of encapsulation. But why do we need GDDs? Of course, for refractory glaucomas. What do we mean by that? These are ones that you cannot control with medication or even with oral, and where TRABs have actually failed or deemed to be failing. There are, in these eyes, more risk factors for failure of filtration surgery. They tend to have more inflammation, or tend to have membranes growing over the angle, or tend to have conjunctiva that is not virgin. And usually it's a combination of the above. So we need GDDs in refractory glaucomas, and you name it, post-surgery as well. Silicon oil, not very uncommon, this feature. Post-trabeculectomies also. I have done many post-trabeculectomy, and this is drug-induced cicatricial conjunctivitis. Forget about the fornix. Look at the bulbar conjunctiva. There's subconjunctival fibrosis. So you do it in neovascular glaucoma, post-VR surgery, post-PK, aphakic, pseudophakic, post-trauma, ICE syndrome, uveitic glaucoma, chemical injury, K-pros, post-fail filtration, you name it, actually. All these glaucomas are difficult to control. So here I'll take you through AGV first. I think most are familiar, but basically this gentleman, young gentleman, had NVG post CMV retinitis, and you can see the anterior chamber filled with blood, and had uncontrolled pressure, of course. What I do is I pre-place my suture 10 millimeters posterior, 60 vicryl, and then I pass it through the holes and then tie it off. I did a vitrectomy to clear off the clot and entered into the sulcus 2.5 millimeters, 3 millimeters posterior to the limbus, and then you trim the tube, you go into the sulcus, and these steps are standard for all tubes. So let's have a look at ADI. There will be more in the next IC, but you have to clear off the muscles. You have to isolate them. You have to clean underneath them. And I prepare the plate a priori. I first check patency, then I occlude with ligature, and then check occlusion Following this, I make fenestrations in front of it and check that it is actually draining in front of the occlusive ligature. You can also leave a vicryl stent, as you can see there, and you can check the drainage again. What you also can do is reduce the size of the lumen by placing a 4-0-proline inside the tube lumen. And after that, you carry on with your usual plate preparation. I'm not going to take you through it once again. Once the plate is placed under the recti muscle, I fix it 10 millimeters posterior to the limbus, and once that is done, the rest of the procedure is more or less the same until you actually, if you have a ripcord, what you do with it, you put it into an inferotemporal pocket, that is if you have a supratemporal implant, and I tuck in the free end under the patch graft. And of course, it's closed routinely. So what are the newer inventions? It's, the ACP250 is very useful for two reasons. It's non-valved, so you do tend to get lower IOP. And the second is, it can be inserted between two recti. You don't have to dissect out the muscles. And the eyelets for fixation are rather anterior. So 6 millimeters is good enough. You don't have to go 10 millimeters. So let's have a look at what other advantage you have with ACP250. You can fold it like a taco. It is so pliable that you can fold it, you can hold it along its longitudinal axis, and you can place it through a very small conjunctival incision. So that's another advantage. Have a look here. I have only opened 5 millimeters of the conch. And once I have prepared the plate, I don't want to show that again to you. I've already shown that, all those features. And this folding, I will show to you in slow motion. You can see how easy, how pliable it is. You hold it with a handshake technique, and then with your right hand, dominant hand, you then hold on to the long axis of the plate and then insert it into your pocket, 5 millimeter pocket. It's folded like a taco. That's what they say. This is a taco technique. And once you have placed it, what you can do is just unfold it. It's very, very advantageous. In eyes, this was the drug-induced cicatricial conjunctivitis where it happened, and the rest is all the same. With the ACP, there is also a ligator block. Ligator block helps you. It's a very pliable tube, so you can tie it off, and you can also make the fenestrations after having, after placing it on the ligator block. Then look at this small incision that I made. You can see end to end the vicryl. It's only 5 millimeters, and the tube is doing very well. So the comparative conjunctival incisions of different AGGs, this is for AGV, that's for ADI, and this is for ACP. Right, so the placement of the tube I would talk about is I do a standard sulcus placement unless it's not possible. Okay, but in pseudophakics and aphakics, there is no reason why you can't do it. In phakic individuals, if they have cataract, I combine it with cataract surgery, and I certainly do that in ICE syndrome. When they don't have cataract, then of course that can be contentious, but a pars plana tube insertion I only do when simultaneous pars PPV is required. So you can see here I have used a technique where I have inserted the tube in the PI window of a patient's previous trab. You can see the tube there. Then length of the tube, I usually keep it long because it allows for retraction, especially in growing eyes, especially in children. And the tube length, if it's long enough, you can reposition later without using any additional hardware. You can see here in this ICE syndrome, there is a little bit of retraction of this. This patient had actually undergone ADI. So, few more tips that I would like to give you, that in pseudophakic, aphakic eyes, you place the tube in the sulcus, helps to prevent endothelial cell loss. If the eye is aphakic, then even in AGV, I will use ligation, albeit partial. And in silicon oil, I actually do intraoperative fenestrations. I'll show you what I mean by that. The tube never gets blocked, and you can consider removal of belt buckle in consultation with a VR surgeon if the patient has a belt buckle. So why in the sulcus? Look at this AC tube. It is causing, over a period of time, it has caused corneal endothelial failure. This patient had trab and tube elsewhere, came to me with 636 vision. Unfortunately, the pandemic intervened and the patient's vision became hand movement. So I had to use a Venflon tube just be another minute. Venflon tube because it was a short tube, I had to use some extra hardware. So this is a high myopic eye who's underwent RK in the past, has had RD surgery, is aphakic. So this patient had AGV, and I ligated the tube. And here, this is silicone oil. I don't know whether you can see the meniscus there, and you can see that the tube itself is patent. And belt buckle, you can easily remove, as you see in this particular case. So there are lots of complications, of course, with tubes, some which are common to all filters, some which are common to all GDDs, like tube exposure, plate exposure, endothelial decompensation, and tube block, but that's for another day. The key points, therefore, I would like to say that tubes are indicated in refractory glaucomas, where failure with trab is expected. They're efficient, but there can be complications. More manipulations are required in non-valved to keep the IOP under control. And initial hypotony is expected, which should be managed preemptively. Just skip the last slide. Thank you very much for a patient listening.
Thank you, Dr. Vanita, for taking us to the whole gamut of tubes and the different tubes available.